Hanley et al. Suggested using the Z value, standard deviation units of the tricuspid valve diameter. Before going to this, we are going to discuss the table 28.1 measurements of valve diameter using decision making. But the Z value is equal measured diameter minus mean normal diameter and standard deviation of mean normal diameter. The normal diameter is the diameter in a normal individual of the same body surface area. The data for the mean normal diameters and their standard deviations also come from the anatomical data of Rowland. A normogram for use in deriving the Z value of the tricuspid valve diameter from the echocardiographically determined diameter and body surface area published by Hanley et al. In reproduced in figure 28.1. The figure 28.1 is in the left tricuspid diameter or Z value, and in below body surface area from 0.1 to 1. Patient with a three-portion right ventricle, those whose tricuspid valve diameter is within the three standard deviations of mean normal, or whose Z value of the tricuspid valve diameter is minus 1.5 or more, will have valvotomy either by interventional cardiological procedure or by surgery. The majority of these patients will not require a systemic to pulmonary artery shunt. If there is infundibular stenosis in addition to the valvular obstruction, the patient should receive a transannular patch placed using cardiopulmonary bypass. The patent foramen ovale is usually left open. By and large, in patients with a patent infundibular whose tricuspid valve diameter is below the 99% confidence limit of mean normal, there is infundibular stenosis in addition to the valvular atresia. These patients are best treated with a transannular patch without closure of the patent foramen ovale and with a concomitant systemic to pulmonary artery shunt. In Hanley's protocol, this applies to patients in whom the Z value of the tricuspid valve diameter is between minus 1.5 and minus 4. In patients without a patent infundibulum, or those with a tricuspid diameter that has a Z value of minus 4 or less, and those with significant anomalous coronary connections, a systemic to pulmonary artery shunt only is performed. A balloon atrial septostomy should be carried out in these patients if the atrial septal defect is restrictive. In terms of timing of intervention, a patient with right ventricular outflow tract obstruction and intact ventricular septum fall into one of the three categories. The symptomatic neonate, who by and large will receive a palliative treatment. The child who survives palliation in infancy. The asymptomatic child with pulmonary stenosis. Symptomatic neonate with critical pulmonary stenosis or pulmonary atresia. Stenosis is usually present in such infants on the first day of life and rapidly becomes more severe as the ductus arteriosus closes. The suspected diagnosis of critical pulmonary stenosis or pulmonary atresia with intact ventricular septum is easily confirmed non-invasively by 2D echocardiography. In some cases, the diagnosis may already have been made prenatally. Echocardiography must provide the following information: size and type of right ventricular cavity, level of atresia, valvular or infundibular and valvular, size and competence of the tricuspid valve, size and confluence of the pulmonary arteries, size of the interatrial communication, size of the patent ductus arteriosus, and left ventricular size and function. Cardiac catheterization and angiography are indicated when right ventricular sinusoidal coronary artery connections are suspected. A right ventricular angiogram will disclose connections between the right ventricular myocardial sinusoids and the coronary arteries. If there is retrograde opacification of the aortic root, there is certainly proximal continuity between the aorta and the coronary arteries. When dense opacifications of the coronary circulation from the right ventricle don't lead to visualization of the aortic root, it is necessary to exclude proximal discontinuity between the aorta and the coronary arteries. A left ventriculography or aortogram is then necessary to study the origin of the coronary arteries and to identify stenosis of the coronary branch linked to the sinusoids. The primary goal of treatment is to maintain an adequate pulmonary blood flow. This ensures survival beyond the neonatal period. In addition, treatment should aim to enable the right ventricle to serve the pulmonary circulation whenever possible, to enlarge a restrictive atrial septal defect, to decompress a hypertensive right ventricle, even if not large enough to serve the pulmonary circulation, and to deal with coronary anomalies if present. Our current management protocol for neonates with pulmonary atresia and intact ventricular septum is as follows. Prostaglandin E is started to maintain patency of the ductus arteriosus as soon as the diagnosis is suspected. For patients with the smallest right ventricles, whose cavity is made of an inlet portion only, a right modified blood oxygen shunt is our procedure of choice. In patients with a patent infundibulum, relief of right ventricular outflow obstruction can be accomplished using a variety of procedures. In many centers, including our own, percutaneous pulmonary balloon valvuloplasty has been replaced open valvotomy for most patients. Using mechanical, laser or radiofrequency energy, the valve is perforated and then dilated with a balloon. Pulmonary regurgitation introduced by the balloon dilatation is generally mild, is usually well tolerated, and doesn't appear to be more severe than that introduced by surgical valvotomy. The prostaglandin infusion is slowly reduced after the procedure and discontinued over the following few days. Surgical intervention may occasionally still be necessary for severely dysplastic valves that cannot be opened by balloon valvuloplasty. Surgical resection of the valve cusps without transannular patching may then be required. Under these circumstances, the procedure is usually performed with median sternotomy on cardiopulmonary bypass. Because postoperative right ventricular performance is not easy to predict, it may be difficult to know whether the patent ductus arteriosus and the atrial septal defect should be left patent or closed at the time of the operation. An outflow tract patch inevitably creates pulmonary regurgitations that interferes with right ventricular diastolic function. It may increase the right to left shunt at atrial level if the atrial septal defect is left open, or causes congestive right ventricular failure if it is closed. Occasionally, if cardiopulmonary bypass is contraindicated, closed surgical pulmonary valvotomy can be performed. The necessity and the timing of a systemic to pulmonary artery shunt remains controversial in patients presenting with mild to moderate right ventricular hypoplasia and patent infundibulum. A smaller tricuspid valve size was the only predictive factor for the need of systemic to pulmonary artery shunt after right ventricle decompression. Management of patients with right ventricular to coronary artery connection remains difficult. Discrete fistula can sometimes be ligated. Right ventricular thromboexclusion was advocated in patients with intramural connections to prevent a still phenomenon into the right ventricle. Patients with right ventricle dependent coronary circulations might be inoperable and considered for heart transplantation. Definitive repair of patients with pulmonary atresia with intact ventricular septum. The main strategies for definitive surgery are biventricular repair in patients with two adequate ventricles, single ventricular repair for very small right ventricle and or right ventricle dependent coronary circulation, 1.5 ventricle for varying degrees of right ventricular hypoplasia. Transplantation in very high risk patients for the above strategies. Our data, the level 1985, have suggested that a 3-portion right ventricle with a tricuspid valve diameter